Welcome to Make America Healthy Again. Join Dr. Charlie Antinori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antinori.
This is Make America Healthy Again podcast. I'm Dr. Charles Antinori, and the guest today again is Dr. Chris Bashian. We spoke to him before about bariatric surgery, a lot of which is done robotically, and today we're going to move on and discuss robotic surgery. So, Chris, want to just go over your credentials for anybody that's listening?
Sure. Yeah. Thanks. I'm currently employed at Inspira Health in South Jersey. I'm the chair for the Department of Robotic Surgery for the network, and also the director of robotic surgery. So we actually have 3 different robots in Mullica Hill and 2 robots in Vineland. And, we cover a wide variety of procedures: general surgery, GYN, urology, bariatrics. So we got a lot to do.
Wow, that really is impressive. Just a couple of years ago, it was just like 1 or 2 robots at each place, right? Yeah.
It was 1 at each, and we just expanded. Yep, we expanded to 2 in Vineland and now 3 in Mullica.
And the schedule stays pretty full, the robotic schedule?
Yeah. I know I do about 130 robotic cases per quarter. And so does so does Dr. Charles McCann, my partner. Yeah. He's doing about 100 per quarter.
Wow.
And then it's not counting. We've got 12 different robotic surgeons at each campus, all within general surgery.
Because Dr. Chang is probably doing a fair amount too, I would imagine.
She does a fair amount too. She's doing somewhere between 80 and 100 per quarter.
Wow.
Yep.
It really, it's amazing.
It's really taken off.
Years ago, like University of Penn had like 20 robots or something like that. So I guess,
yeah,
I guess we're just sort of catching up.
Yeah, honestly, believe it or not, a lot of places are still not really sold on the robot, and it's actually, believe it or not, more common in a lot of the community centers, because there's just so much volume in the community that these are just the robots get utilized. They don't just kind of sit in a closet collecting dust.
Well, I remember that's the story at Cooper, which is now a tertiary, even then was a tertiary care hospital. Around 1998, the medical auxiliary donated a robot. It was like about $1,000 back then. It was Intuitive. It was the same one, basically. And, they set it up in the OR. They set it up in the lobby first so everybody could play with it, like in the lobby of the hospital for a couple of months. And then they set it up in the OR and a few people played with it, but nobody really decided to do anything with it. Eventually, urology really got it going, They started doing like node dissections and things like that, robotically. And I think it really took off with them,
It did. Same thing with GYN. It was like originally designed to get into like narrow spaces like the pelvis, and get into the retroperitoneum around the kidney. And then it just, as it tends to do, it spills over into the other specialties. Yeah. And now it's, I would say across the country, it's about 60% of all bariatric procedures. I think, that's going to eventually turn into 100%, I would say, in the near future. Yeah. Because it's so much better. I mean, especially, like we discussed at the last one, I can do these gastric sleeves with 3 incisions instead of 5, even in big BMIs, 60, 70 BMIs. And we're not breaking instruments. We're not breaking cameras. It's minimal use. The cases are about 25, 30 minutes. So, it's efficient. It's cost effective. It's better for the patients. They are going home quicker. They've got less pain. All of our robotic procedures have a non-narcotic protocol attached to it. So we're avoiding oxycodone and even tramadol. A lot of times we're using Lyrica.
Tramadol's a scam. Tramadol's an opioid.
Yeah, I
agree just marketed it as not an opioid. Then they told me it hits the opioid receptor. So I said, wait a minute.
Yeah,
if it's hitting the opioid receptors, doesn't that make it an opioid?
Yeah, I completely agree with you.
I think it has a second mode of action on the peripheral receptors too.
Yeah. So right, they call it that in between, but it's a narcotic, and we try to avoid it too.
Yeah.
We a lot of times we use Lyrica, or Neurontin, or pregabalin.
I know more and more. I see more and more people taking that. Who was I just talking about? My one of my good friends just had like a cervical disc done. Almost got paralyzed. Just out of the blue. Like really weird. And he just got done maybe a couple of months ago, and they had him on. He just stopped taking Lyrica. It's been a couple of months, but he but they had him on that for quite a while,
Good. Yeah, yeah. It's
non-narcotic.
not. Yeah, it's not narcotic. It's not addictive. You don't get
Yeah,
all the constipation, nausea, all that. You don't get like tired out and woozy.
yeah,
So
right.
yeah, it's much better. So with that, with Tylenol and ibuprofen, we only prescribe the Lyrica for 2 days post-operatively, and then it's ibuprofen, Tylenol the rest of the way.
Right. That's amazing. I
Yeah.
think it'd be really interesting to see. I think the combination of tightening up the border and the tighter restriction. All doctors are writing fewer opioids now than they were just a few years ago. I mean, for everything. I just went.
Yeah.
I wrote a Valium. My brother-in-law needed. He's going to have an MRI, and he needed something because the last time he did one, he didn't like it at all. And I wrote them so. They made a federal case. They eventually filled it, but they basically made a federal case out of filling Valium because I wrote it for my sister, and we
Oh
have a
my
different
God.
last name,
Yeah. Yeah. Yeah.
but
Yeah.
so I can see that things are really tightening up. I really think the combination of less and less prescribing of opioids and hopefully less coming fentanyl and stuff coming across the border, we'll see fewer deaths from all this stuff in the next couple of years. Of course,
Completely
there's
agree.
probably enough
Yeah.
fentanyl in the country to kill us all already anyway.
Already. Yeah, so true. Yeah.
Yeah.
Yeah. I mean, even now, I mean, I feel like I'm seeing more and more people even just refusing narcotics.
Yes.
Even
Right. You
sometimes
see
we're kind
that
of
too.
like, listen,
The
sometimes,
patients
we
don't
do a
want it. It
big
used to be they
operation.
beg
You're
for
like,
it.
yeah,
Yeah.
you're like, hey, listen, you might need a couple for this one.
Yeah.
It's a big operation. They go,
Yeah.
you know what I mean?
Yeah.
Let's try without it.
I think I told you the story about the time I came back from Alabama and I had the kidney stone and I had to stop in to
Yeah.
the at midnight.
Yeah. Yeah. Yeah.
Yeah.
Yeah,
Anyway.
well, the one time I had a kidney stone, I went to urgent care. They gave me Toradol, right? As we
Yeah.
know, non-narcotic completely. It's an
Yeah.
NSAID, and it was like amazing. It was like a
Yeah.
miracle drug.
The
And
same thing happened to me the first time I had a kidney stone. They gave me morphine at first, and that kind of helped. But then they gave me the Toradol, and it like went away.
right,
It really was better.
right, yeah,
For that at that particular. I mean, again, anecdotal, but Well, let's get
right.
back to the robotic surgery. I
Sure,
want
sure.
how many ports can you? How many arms can you hook up to the robot? What's
Yeah,
it's the
so
standard?
it comes with 4 arms that are
Uh,
fully dockable. You can use any number of the four. So it's typically either 3 or 4. You have to use one port for the camera, so that gives you either 2 working arms or 3 working
uh,
arms. Most of the cases that I do personally, we try to cut down to 3 arms because I truly believe less incisions is less painful.
yeah, yeah.
And we use the 4 if we absolutely need it.
I know in the chest, the guy up at Cooper was trying to do the 3 or 4 all in the same interspace, which made
Yeah,
sense to me.
exactly.
You're only getting one nerve, that's
Yeah,
taking the
yeah.
beating.
And that's exactly what we do.
Yeah,
Some of the cases I have done robotically in the chest. A couple of wedges for
yeah,
bleb disease and things like
yeah,
that.
yeah.
And yeah, we always try to
I,
go same intercostal space, eighth intercostal space,
yeah,
three port, 3 8 millimeter ports. You
yeah,
do a nerve block beforehand, and
yeah.
and it's way better than
Wow,
than a
that
big than
really
a
is
big thoracotomy.
amazing. Yeah.
It is, yeah.
Um, Well, one other thing you reminded me, I wanted to mention, it's interesting what you said about the robot catching on in the community first, because that's the story of laparoscopic surgery. Laparoscopic surgery started in Marietta, Georgia, basically.
Mm.
Eddie Joe Reddick and his partner was the gynecologist. They were doing to the
Yeah,
gynecologist, you hate to say it, but the gynecologist
I
actually,
know.
invented laparoscopic surgery.
Right.
Uh,
No
and,
offense to our GYN colleagues, but they always kind of start these things and then we kind of make it a little bit
Yeah,
better,
right. Yeah. Carry it along, yeah.
Yeah,
And
exactly.
they were in a community hospital, and that's another thing that really spread from community hospitals to the major medical centers. It was not the major medical centers that came up with that first. At Cooper, we got the surgeons. There were 3 or 4 major groups there at the time. My group had 5, 6, 7 general surgeons at the time, and again, was total about 15 surgeons got together and bought the laparoscopic equipment. The hospital was like dragging their feet, and the feeling among the surgeons was if you didn't, start doing laparoscopic gallbladders, you wouldn't be doing gallbladders,
Yeah, yeah.
and which
And
is
now, and now, at least, here at our institution, the majority of our gallbladders are all done robotically. And
Right.
and really the goal here, because it can get a lot of flack, especially from other surgeons. Oh, you don't need the robot for this. Laparoscopy is good enough.
Mm.
But really, what it does is it saves the open conversions.
Yeah.
So since I've adopted all of my gallbladders to be robotically. If they're elective, it's 3 incisions instead of 4, and if they're really bad, infected, gangrenous gallbladders, we're 4 small incisions. You leave a drain sometimes, but we're saving all the open operations, and people are still leaving the hospital much quicker. So it
Yeah.
still has that overall benefit, and it provides a cost benefit too, because those are less days in the hospital.
I also remember so a lot of people, even recently when I was working, you have a tough case, let's say it was a gallbladder, or a really bad looking appendix, something, and people say, well, start laparoscopically, you can always open,
Right.
Starting laparoscopically, just opening up the equipment is like, back when I checked on this, which was like, well, I was still at Cape Regional, so it's like 15 years ago, like that's $700 back then just to open up the equipment,
Yeah. Now whenever we do a robot case, we don't even open a general major tray. That's
Is that
all.
right?
It's in the room. It's all closed up. Yeah.
Wow.
Our instrument tray we have a universal robotic tray that has it's got a small stringer of handheld instruments, and it's got 1 or 2 laparoscopic instruments in case we need it. And then the 3 or 4 robotic arms are opened separately. That's
you
it.
can also getting back to the laparoscopic instruments, you can put another port in laparoscopically if you need a retractor or something like that, right? Yeah.
Absolutely. Yeah.
Yeah.
I tried to avoid that
Yeah.
personally. I like to be in full control when I'm sitting
Right.
at the robot, but it's occasionally, you do need it.
Are you getting, when you say full control, have they been able to put in some feedback that you can feel how hard you're pressing on things and stuff like that?
Yes. So we just updated our robots to the newest edition called the DV5, the Da Vinci 5, and it now comes with, they're called force feedback instruments, and it provides you with that haptic feedback.
Yeah.
So as long as you're using those instruments, you get tactile sensation and pressure on all the tissue.
That was awesome. One of the knocks on it. And I'll remember again going back to the early days of the robot when down Dr. Serfolio, I went down to Alabama. Again, he's up I think he's in NYU now, but he was down in Alabama. He'd already done over 1,000 robotic lobectomies when I went down there. And this is 10, 12 years ago. But I watched, and do you have a bedside assistant for this too, for most of your procedures, or no?
Yep, somebody has to be bedside to exchange instruments. Yep.
What do you usually have, a resident as a bedside assistant?
A resident, the OR also has PAs.
Oh, I see. Is a resident on a console with you too? Do you have the teaching consoles or what? Yeah.
Yes, all 5 of our robots in the network have teaching consoles. So if the resident is there with me, we always do have somebody else, whether it be the scrub tech or a PA at the bedside. Yeah,
I see.
So it
sounds really good. So can you let the resident do a lot of it then, if you're just sitting there watching too?
Yeah. So it depends on the level of the resident, and how advanced that particular resident is. Yeah. Sometimes they'll do a portion of the case. The other benefit is we can actually split control of the robotic arms. So really? I can take 1 or 2, and they can take 1 or 2. So wow. I can almost take them through it as if we were open, where like you would use a hemostat and bogey in between.
Right.
I can still do that on the robot if we need.
And that really is interesting that you can split the control of the robot like that. So it's almost the same, like you say, open or laparoscopic, where we basically split control.
Yes.
Everybody would have hands on a couple instruments.
The whole principle behind the robot now is it's not designed to recreate a laparoscopic operation. It's designed to take the place of open surgery with minimally invasive port sites. Right. So anything you can do open, you should be able to do on the robot, barring, select, emergency cases.
Right. Well, that's where the name the intuitive came from. It really is more intuitive. I mean, the little robotic experience I had, I saw that, it's more like regular surgery. Like sewing is the big thing. I mean, intercorporeal sewing, which is, to me, almost impossible laparoscopically because it's backwards,
Yeah, it's difficult. But with the robot, it makes it easy. It's like anybody can do it.
You're moving your wrist the same way and everything, basically.
Right. And also with the new model, you have, when I say, going back to having full control at the console, you have full control of all of your arms. the camera is purely stationary. You don't have an assistant, holding a camera and you have to direct them. You have control, and when it stays still, it stays perfectly still.
Right.
Unlike in laparoscopy, you've got, human tremor moving things around, right? And drift. And also with the new addition of the robot, we can control insufflation, cautery, pressure of the abdomen, all at the console. So that even the circulating nurse doesn't have to get up anymore to control
and do all that stuff.
It's all done by us.
Wow, really, it really sounds like it's. How big is the stapler now? What kind of a port do you need for the stapler?
So there's still the standard 12 millimeter stapler, and we actually also have an 8 millimeter stapler, which we're using actually for appendectomies. We've used it on gallbladders if the cystic duct is very dilated, like a choledocholithiasis case. Or some people are actually starting to use it in bariatric stapling cases, like a gastric bypass, where you don't have any specimens to retrieve. So it's also, you're saving that 12 millimeter port site and a Carter-Thompson closure, a fascial closure, So with that piece, now it's 3 8 millimeter port sites, no fascial closure. We do, tap blocks for pain control, and they all go home with ibuprofen and Tylenol. So even an appendectomy, as simple as that case is, it can still be benefited by the robot.
Right. Well, that's all really amazing.
It's really been great, especially the cases like colon surgery, like we were touching on before, where they were historically all done open, really big incisions. Patients are in the hospital 5, 7, 10 days. Now, when they're purely robotic, people are home within 24 hours. I mean, it's a drastic difference.
How big of an opening do you have to make if you're taking a specimen out, like if you're doing like a sigmoid resection or something like that? And
you do extend, one of the port sites, which is sort of down like where like a Fannin steel would be created. So there's like a low pelvic incision, or you can do a transrectal extraction and you save extraction completely.
Oh, you can do a transrectal extraction?
Yeah. It's like a sponge stick forceps,
up through the rectum. Oh, wow.
Yeah, and just as you're pulling it out, when you're controlling the robot on the inside, you have to hold the edges of the rectum so it doesn't invert on the way out.
I see. Wow, that's really interesting. Yeah. And it fits through. I guess you can get it to fit through.
You obviously, you got to use it for, masses that are of normal caliber, big,
a really big
diverticulitis.
Phlegmon, not going to happen, huh? Yeah.
Right. Yeah. It's got to be sort of normal caliber colon. But by and large, if you're doing an elective operation, barring like a very large tumor, you can get it out pretty small. The other thing is what has actually come back, and you could probably speak to this, is the high ligation for colon resections is now back in favor again, because this is really the technique to be doing it robotically, because that plane that you get into right as the mesentery meets the retroperitoneum is so clean and bloodless that it almost just peels away bluntly.
Wow.
And you're really just dividing things like, if you're doing a left colon, you're dividing the IMA, at its root. And then everything else kind of comes out clean. So you're also getting every lymph node in that region for cancer cases, and you're also getting a much less bloody case.
Wow, boy, that's
Which I'm sure, like you probably know in your career, right? There was the high ligation that came into favor, and then it kind of went away. Right now it's kind of back again.
It's kind of back, huh? Yeah, that's really interesting. Yeah.
I think it's all about the technique too, and just what's easier with the technique.
Yeah, Peter, Senator, makes a big deal. They take that mesorectal fascia and all that, taking the mesorectal. That's easier, I guess, with the robot.
Oh my God, so much easier. It's easier to do it robotic than to do it open. Because you have such good visualization of it, especially in a male pelvis.
Yeah, well, I think that's the two places that there's no question that the robot is going to be the male pelvis and up under the diaphragm. Because I'm telling you, even through a big incision, working under the diaphragm is difficult. And most people, everybody's different. If they have low diaphragms, it's a little bit easier, but that usually means they have bad COPD.
Exactly. That's very true. And foregut's a big part of our practice too. So we do a lot of hiatal hernias, and again, these are all next day discharges. 1 night in the hospital, 23-hour stays. And even, the biggest hiatal hernias that you can see, the type 4, paraesophageals where they've got colon up there and all of that, they're all discharged next day. It's 4 8 millimeter port sites. We actually don't even use a Nathanson liver retractor anymore, which adds another port site. We retract the liver with a stitch, with a suture.
Oh, sew it up like? Yeah.
Yeah, it's like a hammock. So the liver just kind of sits up.
Wow.
And it takes 2 minutes to do, and it saves another port site and opening up all of that instrumentation.
Right. Wow. What do you put a big piece of mesh in those kind of repairs, or what?
So with hiatal hernias, you put 10 foregut surgeons in a room, you're going to get 5 and 5 on either side. I'm a no mesh guy.
I kind of would like to stay away from mesh as much as possible there too. But,
especially around the esophagus and the stomach. Yeah. Also, the data shows that really putting mesh in prevents early recurrence, but late recurrence is the same. So if down the line you have to go back in and redo a hiatal hernia, I think I'd rather go in a stomach that has no mesh around it than one that's completely coated.
Do you PEX the stomach then, or something, like figure out a way to PEX the stomach down in the abdomen or something?
Some people do put like a couple of stitches there to the crura on either side, from the wrap to the crura. I personally don't. Haven't seen any difference in that. But otherwise, no.
I always thought that a lot when I did my hiatal hernia repairs, was like that. The gastrostomy, which we usually did, which probably don't do anymore, but we usually did, was a big part of the operation, because if nothing else, it held the stomach down in the abdomen. The stomach couldn't, again, and the people that get these hernias, there's a lot, it's just a lot of forces pushing that stomach up into the chest. The chest is negative pressure and the abdomen is positive. And in some of these big, heavy people, it's very positive, and that's why you get the recurrences.
The ones that we still do those PEG tubes on are the emergency gastric volvulus patients in like a 94-year-old. You know what I mean?
Right.
That's really it. Otherwise, with the robot, we can dissect so far up into the mediastinum that even a shortened esophagus, you can get enough length to pull back down. You know what I mean? And you can still do a formal fundoplication repair.
Great. Boy. Yeah. Last thing we talked about before we started. You were saying that there's a lot of, the biggest knock probably on the robot has always been cost, because what do they go for now? Maybe they're a couple $1 million a piece, the robot?
The new robot is now 2.5.
2.5, which is really not a lot of money in the grand scheme of hospital expenses anymore.
Right, exactly.
but it's still a lot. It's more than I mean, like I say, opening up a laparoscopic kit is a couple $100, and you got to open up stuff for the robot too. You open up there's disposables, I'm sure.
There are, and so one of the biggest things is if you want to be a very efficient and prolific robotic surgeon, you have to address all those things. And that's really the only way we were able to get these robots to the hospitals, by not only providing good care to the patients, but saving all this cost and being efficient with it, not utilizing the technology frivolously. So you're saving lots of money on the back end by getting people out of the hospital sooner, which is obviously a benefit to them, but it's a benefit to the hospital. You're saving thousands of dollars in that regard. Surgical site infections are down because it's less open procedures. Narcotic usage, as we discussed, is down. So you're really getting benefits on a lot of different fronts.
Right. That's really interesting. And, again, for the non-medical people that might be listening, is, we're saying that a day in a hospital is just a day in a regular hospital bed is probably $7,000-8,000 a day. Day in the ICU, forget about it.
Right. The ventilators
the
involved
bed might be $20,000, and then all the meds and the ventilator and everything on top of that.
Oh my God.
But like I say, even saving, like we always, again, when we started with laparoscopic surgery, we felt like we were doing such a huge we were, doing such a huge service to the whole medical profession in terms of reducing, again, laparoscopic cholecystectomy being the most commonly done general surgery operation. But I think it's the most commonly done operation in the country, cholecystectomy. And, when you're doing, and when I started out, it was like 7 days in a hospital, 3 days with an NG tube. I'm serious.
Right. I believe it.
Then you got clears for a day and then fulls for a day, and pretty much was close to a week in the hospital. I mean, hernias stayed in the hospital 4 or 5 days when I started out. So it really has been amazing. I mean, like say most of your laparoscopic people elective are going home the same day. And, probably 80 and 90% that aren't, that stay, or just stay overnight, where you're a little worried about something. It's really a dramatic change.
Even some of the biggest hernia operations now are being done robotically, like a component separation, which is obviously, a historically very large open incision to do so.
Yes.
Is now done robotically. All from the inside. It's called the transverse abdominis release, if you're familiar with that procedure. Yeah. And so this is usually a one-night stay in the hospital, and
they don't have all that much pain from the tacks and things like that. I've seen where when you tack through the abdominal wall and everything, that they would sometimes get pain from the tacking sutures. That's not been a big, or staples, whatever they use,
So, now it's actually, once you do the release and everything comes back together, you're actually just laying a macroporous, lightweight mesh across the whole space, and it's not sutured or tacked. It's just sandwiched in between, like a stump.
And you close peritoneum over it, or
you close, and you close actually fascia and peritoneum over it from the inside.
Oh wow!
So, wow! So none of it
is it in front of the rectus or behind the rectus? It's behind the rectus, though, to be deep to the rectus.
Yeah, it's between the transversalis and the rectus and oblique.
Oh, I see. So you still have the transversalis underneath it.
Wow. Yeah, correct.
Wow. Yeah. That makes it good, because that's what I always liked about the repair, the open repair I did, was that I wasn't putting mesh. I used to take the rectus muscles and pull them together, and then essentially replace the anterior rectus sheath with the mesh. Close the defect with the posterior, with the edges of the rectus muscle, pulling the two sides together. And it was a really nice repair. Everybody liked it because they were like scaphoid after they were done. You lose about 3 inches.
Yeah.
I'm sure it's the same thing robotically, even better.
Same thing. Yeah, same thing. Just so the pain thing is a little bit difficult with hernias in particular, because you are readjusting the structure of your abdominal wall.
Right.
But you are still seeing a reduction somewhat. You're seeing a reduced time in the hospital. You're not really seeing mesh infections anymore because there's no big open incisions, that kind of thing. So you're still saving a lot of things,
Well, it sounds great, Chris. I think we're about getting about our time. Really, really interesting. I'm learning a lot here.
Well, it's an honor to be able to hear that from you. Who's taught me a lot during residency.
Again.
Of course. Thank you.
Okay, we'll close it up. This is Make America Healthy Again with Dr. Chris Bashian, talking about robotic surgery. Thanks again, Chris. We'll see you again, I'm sure.
Yeah, for sure. Thank you.
See you. Bye-bye.
Bye-bye.